Good afternoon, everyone. I will be discussing on asthma. This is the outline for our lecture this afternoon. First, we're going to be discussing overview of asthma from its diagnosis onto its management. In the management, I will be emphasizing on the current update on the GINA for this year, and finally, we'll be introducing on the different inhaler techniques. By definition, asthma is a heterogeneous disease usually characterized by chronic airway inflammation. The wheezes, shortness of breath, chest tightness, and cough may vary over time and in intensity, together with variable expiratory airflow limitation. So this is an illustration, a simplified illustration on how asthma occurs. So in the presence of an allergen, a sensitizer, virus, air pollutant, or any other trigger, it can trigger inflammation in the airway, which will cause hyperresponsiveness and which would present as clinical manifestation on a said patient. So these are the different inflammatory and the structural cells that are involved in asthma. These inflammatory cells that include mast cells, eosinophils, Th2 cells, basophils, neutrophils, and platelets, together with the structural cells, including your epithelial cells, smooth muscle cells, endothelial cells, fibroblasts, and nerves, both act on or rather release these mediators, including your histamine, leukotrienes, prostanoids, PAF, kinines, adenosine, endothelins, nitric oxide, cytokines, and chemokines, and all of these mediators will cause the different effects related to asthma, and these would include bronchospasm, plasma exudation, mucus secretion, hyperresponsiveness of the airway, and structural changes. There are actually different phenotypes of asthma. When you say phenotypes, it means that these are a subset of patients that would present asthma in one way or another. The first phenotype is your allergic asthma. We also have non-allergic asthma, adult onset asthma, asthma with persistent airflow limitation, and asthma with obesity. Allergic asthma is one of the more common phenotype of asthma, and it usually starts in childhood. It is associated with family history of allergic diseases, including eczema, allergic rhinitis, or food or drug allergy. Patients may present with eosinophilia on sputum exam and are usually responsive to ICS. Sometimes these patients would have a bimodal occurrence of asthma wherein they would start in childhood and then somehow quote unquote disappear during teenage years or early adulthood, and later in life it would resurface, it would recur. Sometimes patients would have history of childhood asthma and would improve or dissipate during over the time, and then it would just recur at old age, or it will just occur whenever the patient would have any respiratory infection. The second phenotype is your non-allergic asthma. These patients would have sputum exam which are neutrophilic, eosinophilic, or even may contain only a few inflammatory cells. These patients would have less short-term response to ICS. The third phenotype is your adult onset asthma. So it means that the patient may not have had any asthma during his or her early years, but when they come to an older age, like after menopause, they would, for women, they would usually present now with signs and symptoms of asthma. So this phenotype is more common in women and tend to be non-allergic in nature. However, they often require higher doses of ICS or a relatively refractory to corticosteroid treatment. Our next phenotype is Asthma with persistent airflow limitation. This is the phenotype for patients with long-standing asthma, wherein they have been having asthma for years, for decades, and are usually uncontrolled. This is primarily due to an air wall remodeling. Next phenotype is asthma with obesity. Patients with this type of phenotype are more likely to have worse or prominent respiratory symptoms and are less likely to be controlled despite higher doses of ICS/LABA. Patients with this phenotype would have minimal eosinophilic airway inflammation. It has been said that fat cells actually have increased release of inflammatory mediators, which are associated with far worse respiratory symptoms compared to the other phenotypes.